Do you remember the homework assignment I gave you to find the 4 leading causes of death in westernized society? That homework assignment where you were to find the 4 leading causes of death in westernized society.
Like the 4 horsemen?
Yeah, those dudes. And one of them had the name, one of them rode the horse, cardiovascular disease. It is the number 1 killer. More so than number 2 and 3 combined. The number 1 killer, more so than number 2 and 3 combined. Is it safe to say, as an EMT, I'll encounter someone that fits this chapter? We're just having a conversation around the dinner table here, okay? This is not curriculum. You know what profiling is? It's kind of got a negative outlook in today's politically correct environment, doesn't it? Profiling is wrong. I can see many ways it is wrong, but it's also accurate in many ways. And when I'm an investigator, am I an investigator? If I'm dealing with your medical condition in hand, I have to be an investigator. I gotta dig for the problem, don't I? I have to form some sort of what we call diagnosis. Now, the diagnosis can come in 1 or 2 forms. There is definitive, and then there is differential. The word differ means what? Different. Means unlike. The word define or definite means that's it. That's it. So in medicine, this kind of goes back to that other chapter, Amber, in the book, but it's a good place to throw it out. In medicine, I make a list of differentials. And sometimes that list is long. Sometimes it's relatively short. So if I was to throw this symptom out right now, nausea. If the chief complaint from your patient was nausea, let's write that over here. Chief complaint, nausea. That's not a diagnosis, is it? That is a symptom because the patient told me. With that alone, what could it be? We got a lot of board. Give me something.
Poison. Ingested poison.
Poisoning. Are you going to take into account anything like food poisoning or bad substance?
Head trauma.
Migraine.
Migraine? Stroke? Shock? And we got all kinds of shock, don't we? I can write more numbers if you want me to. But I think you get the point, right? We're forming a list of differentials. So how do I start narrowing the list?
Find other symptoms.
Okay, keep asking questions, keep investigating, like I said. So we had a set of questions the other day. Do you guys remember this set of questions? Sample history, signs and symptoms, allergy medications. So that could give you some clues, couldn't it? Specifically with this chapter, but I think it's applicable in other areas as well, we're going to ask some other questions. And these are our OPQRST questions. OPQRST. These are questions that really help you in chest pain. I wanted you to throw this up here, and I thought somebody would. I mean, come on, right? Myocardial infarction. That is the new word for heart attack. Heart attack was 5 minutes ago. You are no longer lay people. You are now medical professionals. You will use the term myocardial infarction, abbreviated MI. So when you hear MI, that's what we speak of. Do MIs cause nausea? They can. Now, of the list up there, of the list of 6 on the differentials, which one is life-threatening, or ones? Which one or ones are life-threatening? Come on, I'm going to have to put a little mark out. I'm going to underline the one that you find life-threatening with somewhat red marker. So, stroke life-threatening, head trauma life-threatening? Huh? MI life-threatening, shock life-threatening. Poisoning could be life-threatening. Sure enough, if it was cyanide, huh? The only one you didn't have me underline was migraine. Which migraine could be part of the stroke thing.
Or head trauma.
Or part of the head trauma thing. Or part of the ingested poisoning thing. So sometimes they overlap. So I need more questions. I need to dig into it. So here are the OPQRST questions. Onset. Onset. O stands for onset. When did it start? When did it start? Before I went to bed last night, I had the worst headache of my life. Kind of narrowing in over here, right? Once you narrow in on a differential, your job is now to RO that differential. Rule it out. It's kind of like I have this hypothesis and I want to prove it wrong. I'm running down the road to stroke. Show me something that tells me it's not a stroke. That's called rule it out. And you do that through investigations and questions. So the onset of this nausea was last night before I went to bed. Provoke. What provoked it? What started it? It could just happen. I don't think watching The Price is Right is a very good, I don't think in general that provokes nausea or headaches. It might provoke sleepiness or boredom, unless they won the $10,000 prize, and then you might, hey. But generally, euphoric feelings. A lot different than saying my nausea and my headache started unexplained. I was just lying in bed and it just hit all at once. I don't like things that hit without reason. Something's up when they hit without reason. I have chest pain when I mow the yard with the push mower, but I sit down with a glass of tea and it resolves. That's probably angina. I was watching Price is Right and got a crushing chest pain feeling and I feel like I'm going to die. That's probably not angina because nothing provoked it. It's just that sick that it decided to do it today. You with me? Kind of following my pattern here of investigation? Q is quality. Quality. Just how good a chest pain is it? Quality would be like it's crushing chest pain or it is sharp and stabbing. Those are distinctly different, right? It's dull and achy versus stabbing and jabbing. tightness versus feels like there's a hole in my chest. R stands for radiation or radiating. Radiating. Does it go anywhere? Not only do I have this crushing chest pain, but it radiates up my shoulder and into my jaw. Start to see a pattern here. Remember when you did the sample, what did you get out of this? You got the nausea, didn't you? And you told me all these things it could be, but now that we're asking about the onset and the provocation, the quality, and the radiation, we might start pulling some stuff off of this list. S is severity. This is a very objective question. Subjective question. Subjective question. It's a very subjective question. And I love it because we try to make it objective. It's like going to the eye doctor Friday and they said, what's better, 1 or 2, 2 or 3, 3 or 4? And it's like, if you'll slow down and let me just work on this a minute. And they purposely do it fast. Why? So you're not straining your eyes to make it work out. They want that one that works without anything. They're trying to remove the subjectiveness to it. And so here I am, an investigator, and I'm looking at you and I'm going, how bad is your pain? On a scale of 1 to 10, how bad is it? I don't like that scale, but everybody uses it. Everybody uses it. And somebody will say, I'll make it better, with 10 being the worst pain you've ever had in your life. Well, the worst thing you've ever had in your life is a stumped toe. How accurate is it, right? It's the worst pain I've ever had in my life, and I know pain. Oh yeah, how do you know pain? Because I had esophageal cancer and they did surgery on me from the front and the back at the same time. The surgeons literally pushed their hand through my chest and shook hands on the other side. Okay, that recovery, I busted both femurs falling off a mountain. Oh, okay. I delivered a 10-pound baby and ripped from vaginal opening to anal opening. It's called a grade 5 episiotomy. Okay. We'll talk about that in childbirth when they tear all the way. It's a relative term, right? And it has to be patient specific. And basically what I get out of that is I'm not using the severity scale to try to do anything here. It's a baseline scale because I'm going to give you medications or I'm going to give you treatments or I'm going to get you somewhere. And then we're going to ask this question again in 3 to 5 minutes. Hey, I gave you that nitro, now how's your pain? It was a 6, now it's a 3. Well, I'm going the right direction. I just don't put a number on it and go, okay, that must be really bad because you said 9. Some people over-exaggerate their pain. Some people under-exaggerate their pain just to be the tough guy. Oh, I'm all right, and this guy's gray, ashen, diaphoretic. Looks like death. I'm good. Oh, no, I'm good. It don't hurt. Oh, no, it don't hurt. You lie. And T stands for timing. You know, questions associated with that word. Is it episodical? I mean, does it have episodes? It comes and goes. It's constant. It's on for 3 minutes and off for 2. I mean, whatever. Timing. We're really looking for patterns in the pain. It only hurts when I breathe. Okay. You know? Boy, you get a lot more information now, don't you? You probably heard Matt Moody the other day talk about a drug called Zofran. And Zofran is an antiemetic, anti-nausea drug. It's a drug we have in our ambulance and it's in the medicine community, so some of you may have been prescribed this at home, that stops nausea and vomiting. So if I only went off the chief complaint and I gave the drug Zofran and removed the chief complaint, have I fixed the patient? But if I had went through a good assessment and a good interview and a good investigation and formed a nice list of differentials, could I have moved MI and stroke to the top of the list and kind of worked on that? Because there was no signs of an ingested poisoning anywhere in here. You know, my last oral intake, haven't had anything to eat since lunch yesterday. Well, if I got poisoned at lunch yesterday, it's a damn slow poison. So that's not it. Head trauma, events leading up to the episode. I haven't left the house in a week. And I haven't fallen. And there's no sign of it. And my wife's been with me and I didn't fall. No. So what have we removed? That. Migraine. Do you have a history of migraine? Let's see, where's that at? Past medical history. Most people with migraine headaches have a history of migraine headache. I wouldn't even know what a migraine felt like. No medications for migraines or anything. Is it shock? You know, what do we look for in shock? How do we rule out shock? Is there any fluid loss? No. Is there any blood loss? No. Have you been stung by a bee? Allergic to anything? No. What is your blood pressure? 168 over 110. If you're compensating really hard, right? What's your pulse? 42. It's not a pulse rate I expect to see in someone with shock. What am I left with? Stroke and myocardial infarction. Let's rule out stroke. What comes along with stroke? Neurodeficits, arm drift, facial droop. Do you see how you can't teach assessment till you know everything? Or a lot anyway. You don't see any signs of a stroke. You're not eliminating the stroke, but stroke doesn't have this associated chest pain. What was the other chief? That's the other complaint. Stroke doesn't necessarily come with SOB or dyspnea, shortness of breath. Stroke doesn't often come with diaphoresis, which is just sweating. Stroke doesn't always or often come with gray ashen color. Do you want gray E or gray A?
E.
Okay. Ashen. Ashen looks like ashes. They look like your jacket. They're just gray. Stroke doesn't often come with impending feeling of doom. Impending feeling of doom. It might as well be. It's like, if you've got all this and they say, I feel like I'm going to die, trust them. Over 50% of these will. If I got a chest pain dude in my ambulance, or dudette, a girl, female, they're different. About the only complaint you'll get out of them is the nausea. Oftentimes, females only have the nausea and the weakness. But us guys, we're kind of wimps. We get all the other stuff. Impending feeling of doom. This patient will describe they feel like they're going to die. So if you come to my skit next week, I will raise up, clutch my chest. This is called Levine's sign, L-E-V-I-N-E-S. Levine sign. I'll clutch my chest and go, I don't feel so good. And all the kids go, oh, weird, it's starting. What are we going to do? If I had a blood capsule, I'd bite one, let it come trickling out of my mouth. But I thought an Alka-Seltzer would just be better, start foaming at the mouth. I'm not going to do that. I don't see that as a symptom. Damn it. So all I can do is what? Clutch my chest. So what does that tell you? When I have these chest pain patients, the symptoms can be very subtle. They may be absent. But when you get all those and I raise up out of that dental chair and like, I think I'm going to die, call my wife quick. I need help. Get that out of my mouth No, you're not taking. And when I start combating with them a little bit and saying, I got to get out of here. And they're like, sir, you got to lay down. Let me put a little oxygen on you. I got to go. And then when I get on that ambulance cot and I go, I think I'm going to. There are nurses in that room say, I almost got up to help you. You did too good. You did too good. Believe them, okay? Believe them. Most of them, a majority of them will die. It's better than 50%. They're going to go into cardiac arrest on you before you get to the hospital. And so we're going to spend about 2 weeks here, give or take, dealing with this stuff. I have kind of most likely done that. I'm still not convinced that it's a myocardial infarction. So I'll never shut the list down entirely, but boy, I'm going to work on this, because if it is this and I don't work on it, they're going to die. So this is approaching a definitive list. Now here in pre-hospital world, rarely do we get a definitive. They're out there, low blood sugar, you got sugar, you're better. The definitive diagnosis was you went hypoglycemic. That's pretty definitive, isn't it? But even in the ER, we may not know it's a myocardial infarction. Let me kind of show you some tests that we're going to do. So I'm an EMT, and I walk up, and Frank's complaining of all this stuff. What are the odds I'm right? If I'm playing luck, if I'm playing Vegas, what are the odds I'm right that Frank's having a heart attack? I'd say between 60, yeah, pretty good odds, right? I mean, I'd play the lottery at those odds. I'll play the lottery at a lot worse odds. If somebody told me I could put that dollar up against $500,000 or $1 million or $500 million with those odds, how many can I buy? Yeah, I'm playing. That's pretty good, isn't it? A little old EMT out here can get around that. Paramedic comes along. Paramedic has a device called an EKG, and we can put that 12-lead diagnostic device on, and guess what? So can you as the EMT. The only problem at the EMT level is you can't interpret the printout, but you acquire it and you send it forward to the hospitals or the receiving facility. But we get a 12-lead. So I'm just going to say that's EMT. We could probably even do bystander if you wanted to give them some credit. I mean, they're the ones that called your ass. Let's don't forget about bystander, dude. They're the ones that called you. What are the odds that if they call you on the dispatch and say, hey, come quick, I think my husband's having a heart attack. What do you think their odds are?
1 to 3.
Probably about 50 to 60% themselves, right? Which, Luke, could run me down a Psyops road, couldn't it? Well, if you say that's what it is, that's probably what it is. If he tells you he's had 3 in the past and this feels identical to it, okay, buddy, you should know. You've had 3 of them. I'm just going to put 12 lead. I don't care who gets it. I don't care if it's a paramedic or a ER physician gets the 12 lead. They look at the 12 lead and they see changes on the 12 lead. All of a sudden, y'all, we went up to 90 to 97%. Do you see the importance of 12 lead acquisition? It must be applied properly, and it is not often applied properly. And I promise you, we're going to show you how to apply it properly. You're going to go to the hospital and you're going to come back and say, she said I was doing it wrong. And that's a different soapbox. 90 to 97% accurate. Man, that's important to get that 12 lead, isn't it? And it's important to get it as early as possible. So if I tell you as an EMT that you can take the heart monitor and get the 12 lead and through the use of technology push it forward, transmit it to the receiving hospital, how cool is that? Because now they know with up to 97% accuracy that this patient probably needs to go to the cath lab upon arrival. The cath lab, I'm going to say it one more time, the cath lab is what makes that definitive. That's what makes it 100%. 100% is some cardiologist takes a needle at wrist or in the groin. So you're going to have to shave your junk and push it out of the way. And being for real, because as an EMT, if you have to transport that patient to another facility after they came out of the cath lab, you may be the one holding pressure on that insertion site for the entire trip, having a conversation with some old boy while your hand's next to his junk. Awkward. But it's got to be done. Because are they on blood thinners? Most likely. Have you just put a hole in their artery? Not you, but they did. And you got to keep that from bleeding out. You got a hole in the artery. You got to hold pressure on it until it clots over. That's why they like to go into the wrist now. So if I'm an EMT or a paramedic, especially a paramedic who starts IVs, I avoid starting an IV over here because I want that right wrist to be accessible. So they can drive the catheter. The cardiologist drives. When I say drive, yeah, they're using a joystick and they're guiding this catheter, whether they put it in here or put it in there. And they are driving it up backwards through your arteries until they get to the aorta. And they get at the arch of the aorta where it connects to your heart, where the aorta and the left ventricle connect. Remember that junction loop? The aorta comes up like this. We got a junction right here. The old left ventricle's underneath that. Ding, ding, test question. The coronary arteries originate at the base of the aorta. Wasn't there an aortic valve there? Y'all remember that from our other lecture? We got an aortic valve that's a check valve. It'll open up during systole. During diastole, the valve closes. Is there back pressure on that valve called preload pressure? Afterload pressure? Remember that pressure? That's the pressure that makes the blood go down the coronary arteries. And if you'll look at this heart diagram here, the coronary arteries lie on the surface of the heart. Right there at the base of the aorta is where this is at. So this cardiologist has driven up your leg or through your arm and is setting that catheter right there. And is about to make a determination which coronary artery he or she wants to drive down with that catheter. And they're looking at this on imaging. And they're driving down through here and they go, wait a minute. Let's go over here and look, because the 12 lead said it was probably in this region over here. And they get over here to this region and they go, let's inject some dye. So the dye goes out and the dye stops. The dye doesn't go beyond. Why doesn't it go beyond? Found the blockage. So the blockage is right here. He is in the way. This clot is in the way. And Frank's starving. Frank needs oxygen. So one of the things I can do is I can just kind of push it out of the way to let the blood go through. If that doesn't work, I'll start the drill. And I'll drill the clot out while vacuuming it up, the particles up. And then I will leave, I'm speaking like I'm a cardiologist, I will leave a stent. And a stent is just a culvert, a drain pipe under your driveway. I'm just leaving a fixed slinky looking thing, looks like a slinky. I'm leaving that in that artery and then I'm going to back out. That will keep the artery open and allow the blood to start going back through there. Now, if Frank hasn't died in the process, because Frank's this cardiac cell that was suffering, if he hasn't died, he will recover. Okay? If he's already dead, he will not recover. He will become scar tissue. He will become scar tissue. And guess what? I can sometimes see on that 12 lead if the patient has had an MI in the past, because I can see that scar tissue, kind of. Super cool, huh? So we'll go over and check this other artery. You know, this was blocked. The likelihood of this one being blocked, yeah, there's a little bit of blockage right there. But I can just kind of poke through that and get through it. What if he gets up there and it's like, I can't move it, I can't drill through it. It has, here's a big word for you, Luke, calcified. It's turned to bone. What should be nice and pliable and supple has turned to bone. You say, how the hell did that happen? Well, McDonald's came along several years ago and just kept throwing the trans fats at you, and we started laying down things in these arterial walls called atherosclerotic plaque. Atherosclerotic plaque. And we'll get into this in the PowerPoint. I'm just selling the chapter here. That plaque irritates the hell out of that artery. And so anything that irritates our body tries to encapsulate it with calcium and just kind of, if I can't get rid of it, let me just seal it off in a vault so you won't irritate me anymore. It's kind of like we do the radioactive waste when a nuclear power plant shuts down. I don't want you to bother us anymore, so I'm just going to encapsulate you in concrete. So the body does that by laying down calcium. Now the artery, which was supposed to be flexible and supple, is now hardened. Have you ever heard the term hardening of the arteries? Maybe. Maybe your grandpa said it. Hardening of the arteries. The medical term, Jordan, is arteriosclerosis. So laying down the plaque was called atherosclerosis. Hardening of the artery is now called arteriosclerosis. And you can't drill through it and you can't expand it because it's hardened, it's bone. Now what are we going to do?
Bypass.
Now we're going to bypass it. Now we're going to crack your chest open, and we're going to take a little DeWalt saw and go right down the middle of your sternum. We're going to take a set of spreaders, we're going to stick it in that hole, and we're going to crank the spreaders. And they're going and they're going to pull your rib cage back so your heart's sitting there going da-dum, 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 da-dum. Now it's hard for me to sew on a heart when it's doing this. Once again, I'm speaking as a cardiologist. Let me stop it. Let me put you on a heart-lung bypass machine. And somewhere in the meantime, I got to go down in your leg and I got to start harvesting an artery. I have to go find an artery in your leg that you don't need it down there as much as you need it up here. So let me just strip one from your leg. So I'm going to go hunting. I'm just going to cut, look. Sometimes the bypass surgeries can't be done because they can't find a healthy enough artery in your leg. So remember that McDonald's trans fat fries that laid in there all these years? Do you think it only targeted that one cell or that one vessel? It laid it down everywhere. Sometimes it's laid down in the leg so bad we can't even find a suitable artery down there. Not to jump forward to chapter neurological, I think it's chapter 21, neurological emergencies. But what's good for the heart's good for the brain. What's bad for the heart's bad for the brain. Did that trans fat stuff from the McDonald's fries, poor McDonald's, I'm picking on them today. Their fries were much healthier when they were fried in beef tallow. But in the name of PC, they changed it to canola oil. Do you think it's laying down in the brain? And if that artery issue had happened in the brain, it wouldn't be a heart attack. It would be number 5 or number 4, stroke. That make sense to you? So whatever risk factor you have for heart disease, same risk factors for strokes or cerebral vascular disease. The big umbrella over all this, it's one of your 4 horsemen. They're riding the horse called CVD, cardiovascular disease. And when they say vascular, that means all over the body. So we happen to find an artery in your leg that will work. So we will cut a piece of that artery out and we'll fix that wound we just created. We'll take that piece of artery and we'll go up here and we will sew in here and then we'll stretch it around the clot, and then we'll sew in there. So now you had a blockage here. Now we put in a bypass. And so when you hear the word bypass surgery, that's what they're doing. Some people have multiple bypass surgeries at one time.
Yeah. My boss from my last job, he had to have 4.
4 bypasses at one time?
Yeah.
Sick son of a gun, wasn't he?
No, he was pretty healthy before that.
No, he wasn't. I'm telling you, he was not. I'm telling you, he was not. Why do you say he was?
I don't know, he ate decent. I mean, he had a lot of energy drinks, but he built pools. He was strong, so.
But apparently something wasn't working.
Yeah, no, something was not working.
Something didn't go down right, did it? Something was wrong in the water. Okay. So ding ding test questions. One of the things we do have to know are, what are the risk factors for all of this bullshit? What are the risk factors for all this? Yeah, go ahead. Can you give me one?
Risk factors for
Cardiovascular disease.
oh.
How about age? Let me start it out. Age.
Risk factors of age?
No, risk factors for cardiovascular disease.
Okay.
Diet.
Oh, wait, I'm supposed to start talking. No. Does he want me to answer?
Yes.
Oh, okay. Sorry.
And I apologize for having to do this, but it was important. Most people know not to text me, so and I've got it listed to people who can. I'm sorry.
Diet.
Okay, let's be specific. So
Specific.
age. Age is one of them.
Okay.
The older you get, the odds of this happening go up. We used to see signs of cardiovascular disease in like early signs, 20, 21-year-olds, somewhere in there. That's how bad it was. And I'd say in the 1990s, we started seeing the onset of cardiovascular disease at your age. Current research says it's showing up at 13. So this is not an old person problem anymore. Now, the older you get, the closer the horsemen get to you, all right? But don't pull it off your list just because they're 35. There are plenty of people at 35 years old having heart attacks. It's getting younger all the time. But age, the older you are, the more risk. What else? Gus? Let Gus have one.
Diet.
Diet. What kind of diet?
High fat diet.
Knew you'd say it. Guys, we gotta drink the Kool-Aid, but we don't have to swallow it. So textbooks are going to say a high-fat diet is a contributing cause to this. I will say the wrong kind of fat will contribute to this. They have it backwards. I'm telling you that for your own safety. If we go with the books, though, you're correct, Gus. A high-fat diet. It really pains me to say that. It really pains me to say that. We have been blaming fat when sugar was the problem. This is a fact. This can't be debated. This doesn't need research other than data collection, and once you collect the data, you see it. The number one comorbidity factor, which means what other disease can you have that makes this one even worse, the number one disease that's hitches a ride, it's probably chained up or saddled up with the other horsemen, type 2 diabetes. Type 2 diabetes. So if the patient has type 2 diabetes, they can have type 1 as well. Let me change that word a little bit and call it metabolic syndrome. So one of your homework assignments, which is, I have you do those so we'll have a better conversation tomorrow. I want you to research metabolic syndrome. And so Jordan, I know you've been asking about your blood sugar. That's one piece of metabolic syndrome. We also have to have a high waist to height ratio. You don't have a problem there. I don't think your blood pressure is high. Okay? Your BMI, I think your BMI is fine. But those are components of metabolic syndrome. And then metabolic syndrome eases over into insulin resistance, and insulin resistance eases over into type 2 diabetes. When you see all of that, heart disease is always there with it. Gus, we're blaming fat for a sugar crisis. I'm telling you that for your own benefit. The textbooks, the American Heart Association, they love those carbs.
So added sugar or just all sugar?
All sugar. Sugar. Some sugar is more provocative of an insulin dump than others. That's why you don't drink your juices, because it's fructose. And that causes a spike in insulin so quick versus glucose. Table sugar is 50-50, 50% glucose, 50% fructose. Now, if you eat an apple, you're okay because you got enough fiber in there to slow down the process. But if you're drinking the juice, you're eating a whole bushel of apples. You're eating the sugar from a whole bushel of apples with none of the fiber. Pulp doesn't count orange juice, people. Probably counts some, but you're not getting all of it. What else? What are the risk factors? Tobacco use. Very good. Tobacco use. If you're drinking the Kool-Aid, don't swallow it. What do you know about cholesterol, Billy?
Not a lot. Not even a sliver, honestly.
Okay. Well, you said something about it, like it was a risk factor, so.
I hear it all the time that.
You will, and you'll see it in your book, too. Well, Luke, what do you know about cholesterol?
Well, I know that it causes clots.
What if I told you cholesterol was the precursor to all the hormones in your body, like testosterone and estrogen and all those other things? Like if you didn't have any cholesterol, you wouldn't have any testosterone. Well, that doesn't sound real good. What's one of the drugs that will give you if your cholesterol's too high?
Just
I can tell you what it ends with. It'll end in the word statin. S-T-A-T-I-N. Avoralstatin, norvastatin. If it's a statin drug, it's designed to lower your cholesterol. Wonder why we have a tea epidemic in this country, too. Cholesterol has, oh God. You know how hard it is for me to lie to you? It's hard for me to lie to you. There is a large percentage of people in the hospital, in the cath lab, at the definitive level, and when I say definitive, they have had or are having an MI who have normal, what they call normal cholesterol levels. Yeah, it's hard on the liver. Yeah, if you take statins, you have to go back for liver enzyme checks because it burns your liver up. It causes your liver to not make any more cholesterol. And we said it come from eggs. And it didn't come from eggs. Your body will make its own cholesterol. A lot of people think there are two types of cholesterol, HDL and LDL. Have you heard those phrases before? High density lipoprotein, low density lipoprotein. The L's the bad one, it's the lethal. The H is healthy, the healthy cholesterol. There's only one cholesterol. There's not these two distinct forms. The density means how deeply that molecule can hit and burrow into the arterial wall. So the low density or smaller particles, they can irritate the lining. They probably should be looking at a subcategory of all of that called ApoB, but that's not mentioned because the test for ApoB is not supported by the insurance companies. I'm telling you for test purposes, cholesterol is correct. You don't need a cholesterol level of 900. Okay, that's a little excessive, right? But they keep lowering the standard of the cholesterol. For what reasons? We might suspect. More drugs to fix it. More pharmaceuticals. Here's my personal take on all this. We've got all these drugs. We've got all this diet. We've got all these associations and organizations. And we've got, for every workout center, Planet Fitness and the like that we have on a street corner, on the caddy corner to that is a kidney dialysis center. Of all we've been doing since the 1950s, this is still the #1 cause of death in the westernized society, outrunning #2 and #3 combined. Something ain't working. Your top 10 medication list, most of them were to address something like this, and then the rest of the medication was to address the side effects of the medication that was supposed to be doing something like this. So you take the blood pressure medication, now you're impotent, now you take statins, now you're low on sex hormones, now you're depressed because your quality of life has went in the tank, now you're on antidepressant, and you end up in the cath lab still. Something ain't working, y'all. But you're going to encounter people that have this issue every day. You're correct. High cholesterol has a name. Hypercholesterolemia. High blood cholesterol. High triglycerides. Insulin resistance. High triglycerides, which has a name called hyperlipidemia. Lipid means fat. Hyper means a lot of. Emia, I don't know how to spell it, in the blood. Should be an I. Hyperlipidemia. High blood fats. You know where the high triglycerides come from? High sugar intake. High sugar intake that doesn't get absorbed into use and used by the cells immediately, like you don't go earn your sugar. Then it floats around in your bloodstream in an energy form called a triglyceride. 3 glycerins, glucose molecules tied together in 3, bunches of 3, triglycerides. And they float around for about 48 hours to see if you might use them in periods of fasting. Oh, hell no. I get my sugars every 4 hours, and 2 if I get a snacky. And so your body never has the opportunity to get rid of the triglycerides. Your triglycerides start creeping up in the 2 and 3 and 400 range, 500 range. I've seen people with triglycerides at 700, and I'm sure they go even higher than that. They're supposed to be less than 100. If you take fat, and I'm not necessarily saying healthy fats or unhealthy fats, I'm just saying fats in general, and you mix them with sugar, what do you get?
Glucose. Wait. What did you say? Say again?
Fat and sugar mixed together gives you
Twinkies.
cake icing.
Oh.
Cake icing. So how do you think your little old vasculature, your microvascular, your capillaries, your arteries, how do you think they respond when you push cake icing through? Because remember, you had high triglycerides, and Jordan said insulin resistance, and so your blood glucose is up. I'm doing your homework for you. Your triglycerides are up. Your cholesterol is up. That just kind of goes with the game sometimes. So what's happening in the microcapillary beds of your eyes? Blindness, kidneys, kidney disease, penis, erectile dysfunction. Capillary beds of the heart muscle, clots, heart attacks. You ever heard the saying that the eye doctor, it's not a saying, but the saying is the eyes are the window to the soul. And your eye doctor is often the one to diagnose you with diabetes, because the eye doctor can see the damage at the capillary beds on back of the retina and tell you, you need to go see your PCP. I think you've got early retinal issues. And you go to your PCP and they come out and they go like, wow, your blood work is terrible. It's off the charts. You've got all this stuff going on. And then it's so bad that we're going to refer you to nephrology, which is a kidney doctor, and make sure your kidney function's okay. And then they're going to look at your feet and go, did you know you had sores on your feet that weren't healing? You're like, no, I can't even feel my feet. You can't feel that? No. Oh, you've got diabetic neuropathy then. And so the nerves have been damaged so bad in your feet, you don't even know when you have a wound. And if there's no circulation down there, there's no healing of that wound, so it becomes gangrenous or infected. These are people you will encounter. These are people you'll encounter. And you don't want to be one of them. I have never transported, and when I say I've never transported, stay with me. I have never transported someone with their chest ripped apart, even though I've transported hundreds of them, that said, this is a good day. Every old man that I took from Denison to Baylor Hart with wire stitching holding his sternum together, lying flat on my cot because you can't set up. You can't sit up for 8 hours after you have this procedure, with my hand in his groin holding pressure. I never had one of them say that was a good day. But every one of them said, boy, because I was young, you know, and they're old, right? They were my age that I am now. They said, boy, get your shit right. You don't want any of this. And I'd say, you're right, I don't. This looks terrible. It was making me sick at my stomach because I don't want my hand here, for one. And number two, I saw your chest, and that's terrible. And number three, if you crash on me, I've got to work on you. If you die on me between here and Dallas, I get to work on you and find a hospital to take you into. Okay. Okay. Do something about it. Do something about it. Don't drink the Kool-Aid. Don't drink the Kool-Aid. The food pyramid is a scam, guys. It's an absolute scam. Natural foods in as natural form as you can find them. We're blaming the wrong stuff. More risk factors. Smoking, type 2 diabetes.
Would genetics be one?
Genetics. So now we're starting to create a modifiable, non-modifiable list. So some things we can fix. We can fix smoking, we can fix diet, we can fix exercise, we can fix a sedentary lifestyle, but we can't fix our genetics. Sometimes you just suck at the genetic lottery, right? What else?
Obesity.
Yeah. Metabolic syndrome, obesity, poor BMI, and that's going to be in your homework tonight when you look at metabolic syndrome. Modifiable? Absolutely. Sedentary lifestyle. Modifiable? Yeah, get up and move. We're all meant to move. Environment? Sure, there are some environments that just aren't healthy for us to be in. High stress, no play. Let me tell you this and then we'll go for the day. Do you think people, researchers, physicians, and the like scientific community, whatever you want to call it, has been trying to find out who lives the longest and who is the healthiest when they live that long? Do you agree? They seek these people. So in the they've done it worldwide, but in the United States, somewhere up in the New England states, and don't know where or what village it was in, and I say village because it was a village-like, some community, they found people who had no heart disease in that community. It's the #1 killer in the United States, but they found a place where it didn't even exist. So they went to research it. Look at demographics. We got young and old. Look at jobs. Jobs don't look any different than anybody else. Look at diet. Their diet's as crappy as anybody else's. Do they drink red wine? No. Damn. Everybody wants red wine to be the cure, don't they? Well, what the hell is it? We can't find anything odd about these people. Odd meaning different than the norm. But they have no heart disease. Here was the difference when they really sat down. I mean, they had to kind of like live with them to find it. They were looking at all the extrinsic factors and couldn't find anything. They went and lived with them to figure out what this was. When they ate, they cooked it. When they ate with family and friends. It was communal. They sat down together. They sat at a table. There were no outside distractions, no TVs, no cell phones, no newspapers, nothing. They just sat at a dinner table and they ate slowly and they laughed and they talked and they sat at the table after the meal was finished and continued to laugh and talk. And then they go about their day or their night or their morning. They knew where their food came from. They prepared their own food and they shared the food. That was the only thing they could find. And I think there's a lot to that. I think when we grab something and we order food by number, it's even worse today. We have to scan a QR code and we give it some Mexican name and that sounds all sexy and that's what we want to eat, right? I'll take the calara. I'm like, what the hell is that? That's some more of this stuff wrapped in different stuff with a different cheese, and I can use the permeations and combinations of all the different ingredients you have back there and have a menu that I need a QR code to eat from. I just want an enchilada. Beef, please. Whew, getting wound up. It is time to go. It's a lot different than sitting down and preparing their own meals. So I don't think it's hard to figure out why this is the #1 cause of death and disease in the United States. It's not hard to figure out at all.